The closure procedure is an effective treatment alternative for patients with superficial venous reflux. The venous closure system utilizes a radiofrequency generator and an endovenous catheter to heat the vein wall and occlude the vessel. This videotape is not intended to replace the product instructions for use, operator's manual, or in-service training. The closure system provides a controlled procedure with temperature, impedance, and power parameters monitored and clearly displayed, allowing valuable information about the treatment. The procedure is typically performed on an outpatient basis under local anesthesia, and with experience can be completed in 45 minutes to 1 hour. After the catheter is inserted into the refluxing vein, the electrodes are deployed. RF energy heats and contracts the vein wall, shortening and thickening the collagen fibrils. The catheter is slowly withdrawn. The denuded vein is physically narrowed as a result of this treatment and undergoes a fibrotic sealing after this controlled thermal injury. Research has demonstrated that controlled heating of the vein wall causes shortening and thickening of collagen fibrils, along with significant reduction of vessel diameter and subsequent fibrotic occlusion and resorption of the treated vessel. Patient selection begins with a duplex ultrasound examination to diagnose superficial vein reflux and to assess vein anatomy, diameter, and depth. Tumescent anesthesia may be prepared prior to the case. The solution most commonly employed is a mixture of 1% lidocaine with epinephrine, 1 to 100,000, diluted with normal saline. Sodium bicarbonate may be added to reduce the sting of infiltration. The purpose of tumescent anesthesia is to provide vein compression, exsanguination, and to protect surrounding tissue from thermal injury. Just prior to the procedure, the treatment vein is mapped. Significant anatomy is noted, and potential vein access sites are identified. The 6 French catheter electrodes expand to 8 millimeters, and the 8 French catheter electrodes expand to 12 millimeters. Many experienced users have effectively treated larger diameter veins with vein compression techniques. The leg is marked to identify the path of the vein, the saphenofemoral junction, significant anatomy, and the desired vein access site. With the patient in the reverse Trendelenburg position, ultrasound guidance is used to locate the vein access site, usually just above or below the knee or at the ankle. Local anesthesia is used at the access site, and the needle is inserted into the vein under ultrasound guidance. Flashback at the needle hub confirms vein access.
We're inserting the guide wire.
A guide wire is passed through the needle, followed by a standard introducer sheath, which is secured to the skin. To avoid venospasm, keep the patient warm and relaxed. Use reverse Trendelenburg positioning to promote venous fill. And consider applying nitroglycerin paste over the access site prior to attempting vein access. Estimate the length of catheter to be inserted and set the shaft markers. Note that catheter marks are 1 centimeter apart. Turn on the venous RF generator. Connect the Closure Plus cable. Note that the generator automatically begins continuous monitoring of temperature and impedance. Adjust generator menu options if desired. Connect the heparinized saline drip. Verify the drip rate at the catheter tip and in the chamber. To ensure proper functioning of the closure system, an optional impedance test in saline may be performed. Confirm that appropriate values appear on the generator's color display screen. Note that the temperature of the saline will affect both the temperature and impedance values. Values in the green range are optimal. With electrodes closed, insert the catheter and advance it to the most proximal treatment point, usually the saphenofemoral junction, under ultrasound guidance. Open the electrodes after reaching the saphenofemoral junction and approximate the catheter treatment position. The starting catheter tip position should be 0.5 to 1 centimeter inferior to the saphenofemoral junction, or just inferior to the ostium of the superficial epigastric vein. Next, infiltrate the vein segment to be treated with tumescent anesthesia solution. Inject the solution directly into the saphenous compartment with a 20-gauge needle, creating a 360-degree perivenous envelope around the treatment vein. The final positioning of the catheter tip at the saphenofemoral junction is done under ultrasound guidance. The open electrodes are identified and the catheter tip is positioned 0.5 to 1 centimeter inferior to the saphenofemoral junction, or just inferior to the ostium of the superficial epigastric vein if visualized. The catheter shaft markers are adjusted according to the final set position. Deliver the final injection of tumescent anesthesia at the saphenofemoral junction. Rescan the length of treatment vein to ensure adequate vein-to-skin depth. Additional tumescent anesthesia should be infiltrated in areas where the vein is less than 1 centimeter from the skin surface. Move the patient into 15 to 30-degree Trendelenburg position. External compression is applied over the saphenofemoral junction. Press the body test button to check impedance values and to assess electrode contact with the vein wall. Values in the green range are optimal. RF energy is turned on. Target temperature should be reached within 10 to 15 seconds. Catheter position is held for an additional 15 seconds before beginning pullback to ensure transmural heating of the vein wall. Then catheter pullback is initiated. Power is automatically adjusted to maintain temperature. Pull back the catheter at a rate of 1 centimeter per minute for the first 5 minutes and no faster than 2 to 3 centimeters per minute thereafter. As the catheter is withdrawn, the electrodes heat the vein wall, collagen fibrils contract, the endothelium is denuded, and the vein lumen is acutely narrowed. This stimulates fibrotic sealing and occlusion of the treated vein. During pullback, temperature, power, and impedance are closely monitored. Values in the green ranges of the colored gauges are optimal. Catheter pullback continues until the electrodes enter the introducer sheath. Then RF energy is turned off and the catheter is removed. Vein occlusion is confirmed with a postoperative ultrasound scan. The deep venous system should be checked for patency. After verifying procedure success with duplex ultrasound, the introducer sheath is removed. Compression is applied locally to achieve hemostasis and a steri-strip is applied. Postoperatively, wrap the patient's leg with an elastic bandage or apply compression hosiery. Patients are encouraged to ambulate regularly and to avoid heavy lifting and long periods of standing. The patient should return for a follow-up duplex scan within 72 hours.